Hi, my name is Chris Sutton, and I'm going to be doing my maintenance of paralysis video number 6. I'm going to start with my machine check. I'm going to check my pipeline pressure, make sure that it's at least 50 psi, and also make sure there's no pipeline crossover. I also want to check my E-tanks, ensure that they're at least halfway full and my key's available. I'm also going to make sure I have my ambu bag available, and also my suction, but I'm going to connect my suction to make sure it's functioning appropriately. It looks like it is. I also want to make sure I have my extra airways up here available, and my emergency airways, and also my apples available, ready to go. I'm also going to check my flow meters to make sure my Link 25 is functioning appropriately. I'm then going to go ahead and do my low pressure check, pull out my bowl. I'm going to make sure that there's no leaks with my flow meters or with my vaporizers, and I want to make sure my vaporizers are full enough for this case. I'm going to turn on my machine, make sure there's AC power. I'm going to make sure I'm going to calibrate my O2 sensor and check my CO2 absorber and ensure it's not desiccated or exhausted. I'm also going to check my monitors, ventilators, make sure they're set for this, they're appropriately set for this setting. I'm also going to check my inspiratory and expiratory valves, make sure they're functioning appropriately. And now I'm going to be doing my high pressure check. I'm going to turn it to the manual mode and turn my PO valve all the way off. I'm going to include my Y piece. I want my pressure to be at least 30 centimeters water. Make sure that holds for at least 10 seconds. That looks good to me. All right. Okay, now we have our patient, John Doe. John Doe is a 43-year-old male coming to the OR for laparoscopic inguinal hernia repair. He has a history of poorly controlled type 2 diabetes, hyperlipidemia. He did have a previous previous myocardial infarction within the year. He did have some traumatic brain injury a couple of years back. The meds that he's currently taking are aspirin, metformin, and atorvastatin. He has a BMI of 27. That's based off of his height of 170 centimeters and weight 80 kilograms. Labs that we took were CBC, BMP, blood sugar of 194, and a CT that showed an umbilical hernia. So I'm going to go ahead and do an airway assessment. John, can you open your mouth and stick out your tongue? He has a Mallampati score of 2, class 2. John, can you lift up your head for me? Perfect. He has a thyromental distance greater than 7 centimeters. John, can you bite your upper lip? I'd say he has an upper lip bite of class 1. John, can you open your mouth as wide as you can for me? I would say I'm able to, for his entire incisor distance, I'm able to fit at least 3 fingers in his mouth. His neck length and girth is within normal limits. John, can you move your head side to side and up and down? I would say he has full range of motion. I'm going to go ahead and auscultate your heart and your lungs. Perfect. I would say those were within normal limits. Now I'm going to ask you some questions, John. John, have you had any medical problems, heart, lung, or stomach, or any previous injuries, or excuse me, previous surgeries? John, have you or your family members had any issues with anesthesia in the past? Have you or your family members ever had something called malignant hyperthermia? Apart from the medications that we talked about, are you taking any other medications? Are you aware of any known allergies? What did you have for breakfast this morning? John, are you able to climb 2 flights of stairs or walk 2 blocks without feeling winded? Based off of this physical assessment, I would say he has an ASA of 3. Okay, so our plan for today is we are going to be doing a general anesthesia, John. Indications for this is, since you're doing a laparoscopic surgery, it's important that we paralyze your body in order to perform this procedure, but this is only temporary. Risks with this are nausea, vomiting, sore throat, respiratory complications, allergic reactions, post-operative delirium, and the life-threatening condition known as malignant hypothermia, which is kind of a low risk, but we'll keep an eye on that. Benefits of doing general anesthesia is you will not be aware or remember the surgery. The surgeon will be able to perform the surgery with small incisions, and your pain will be under control. Alternatives is, unfortunately, we have to do general anesthesia because we have to paralyze your body for this procedure. So general anesthesia is what we need to perform. So I have informed the patient, I have obtained consent. I'm going to go ahead and gather my equipment. I have ET tube sizes 6.5, 7, and 7.5. I have a 2 Miller blade and a Mac 3 Miller blade, or excuse me, Mac 3 blade, a stylet. My induction medications are drawn. I have my nerve stimulator as well as my reversal neuromuscular agent, neostigmine, and I also have glycopyrrolate to go in conjunction with that. I have my surgical blankets for positioning. Okay, I'm going to go ahead and for my pre-induction, I'm going to go ahead and give John I'm going to prep him for his induction. Okay, John, I'm going to give you something that's called midazolam. That's just going to kind of help you relax. After placing a 20 gauge IV in his left forearm, I'm going to give him 2 milligrams of midazolam, and then we're going to transfer him to the OR. Okay, we're going to make sure he's in the supine position with blankets under his head to kind of put him in the SNP position for an optimal position for intubation. And now I'm going to place my monitors, my pulse ox, my non-invasive blood pressure cuff, my 5-lead EKG because of his previous MI, especially within the ear. And then I'm going to go ahead and pre-oxygenate him. And we're going to give you some oxygen here to get you ready for intubation, okay? Oops. All right. Okay, we're giving him oxygen, 100%. We're going to do that for about 3 to 5 minutes. Okay, so now that he's being pre-oxygenated, I'm going to go ahead and give his induction medication. I'm going to give 100 micrograms of fentanyl, and I'm going to give 160 milligrams of propofol. That's based off of 2 milligrams per kilogram. I'm going to grab my nerve stimulator. I'm going to stimulate his corrugator supercilii, and I'm going to use a train of 4, and I'm going to look for 4 twitches for my baseline, just to make sure that his twitches are working. And so after doing that, ensuring that he has at least 4 twitches for his baseline, I am going to give him 80 milligrams of rocuronium. That is based off of 0.6 to 1.2 milligrams per kilogram. Okay, so now after waiting a little bit and letting the paralytic kick in, I'm going to check again. And what I want to see is a fade, a decrease in his train of 4. And so ideally I want to see 0 twitches out of 4. So 0 twitches out of 4 is optimal for intubation. I'm going to ensure his eyes are taped shut. I'm going to grab my size 7 ET tube. I'm going to grab my Miller blade. And we are going to intubate our patient. And I have my stylet with my, if I didn't mention my stylet, I have my stylet to kind of help guide my ET tube in. All right, see the vocal cords. I'm gonna go ahead and intubate. Once I pass the vocal cords, I'll take out my stylet and I'll advance a little bit. At the teeth, we're at about 23 centimeters. I'm gonna take the tube. I'm going to go ahead and inflate the cuff, connect him to the machine. So I'm going to assess for ET end tidal CO2 waveforms. I'm also going to auscultate for bilateral breath sounds and also check for chest rising to confirm placement. Now that I've confirmed placement, I'm going to turn on my sevoflurane to 1.8%, and I'm going to titrate that up and down based on the patient's clinical presentation. Okay. So this procedure typically will last 45 to 90 minutes, so I probably won't need to redose rocuronium, but in cases that they're longer, I could use the train of 4 to ensure adequate paralysis. So 1 to 2 twitches of train of 4 is optimal for surgical maintenance. So if I need to redose, I would do, for rock, I would give 0.1 to 0.2 milligrams per kilogram every 15 to 30 minutes. So that's about 8 milligrams for this patient specifically. Okay, so now we're at the end of the case. We're going to assess the block depth with the nerve stimulator to determine how much reversal to give. So using the train of 4, it's best to wait until the return of the 4th twitch. So prior to the administration of neostigmine, even though this is not guaranteed to produce adequate reversal, ideally we want to see the 4th twitch to be 90% of the strength of the 1st twitch. So instead of doing the corrugator supercilii, we're actually going to do the ulnar nerve, and we're going to assess the adductor policies. Okay, so it looks like he has a train of 4 ratio of greater than 0.9, I would say. So we're gonna go ahead and give his reversal. And in conjunction with neostigmine, we're gonna give glycopyrrolate. So we'll give 4 milligrams of neostigmine, and then we're gonna give, and that's based off of 0.5 milligrams per kilogram. And then we're gonna give glycopyrrolate 0.8 milligrams because 0.2 milligrams is glycopyrrolate. We're gonna give that because 0.2 milligrams of glycopyrrolate for every 1 milligram of neostigmine. Okay, so I'm gonna give my 4 milligrams of neostigmine, and I'm gonna give my 0.8 milligrams of glycopyrrolate to counteract bradycardia. Okay, so we're gonna go ahead and after we reverse the patient, we're gonna discontinue the SIVO, and we're gonna give 100% oxygen here. All right, so we are going to do a deep extubation. We'll ensure comfort of the patient, but we'll make sure that the patient is within appropriate ventilator settings and make sure that we have spontaneous breathing. So I'm going to go ahead and extubate our patient here. Okay, go ahead and we'll deflate the cuff. Take the tape off the eyes, take the tape off the tube, and I'm going to go ahead and suction as I take out the tube. Perfect. And I'm going to put a nasal cannula on. Oops. 4 liters. And we're also with that we're able to assess end tidal CO2. Sorry, I'm having a hard time putting this on. Perfect. Okay. All right. Okay. He's on 4 liters nasal cannula. Looks like he's stable. We'll take him back to the PACU. Okay, I'm going to give report to Nurse Daniel. So Daniel, this is John Doe. He's a 43-year-old male with no known allergies who has a medical history of poorly controlled type 2 diabetes, hyperlipidemia, an MI within the last year, and a traumatic brain injury a couple of years back. Came in for a laparoscopic inguinal hernia repair. We have a 20-gauge IV in his left forearm. He was stable intraoperatively. His blood loss was minimal. He did receive 500 mils of LR preoperatively and then 500 mils of LR intraoperatively. He was given 2 milligrams of Versed preoperatively, 160 milligrams prop, 100 micrograms of Fent, and 80 milligrams of Rock. Was also given a reversal for the block, for the paralytic, 4 milligrams of neostigmine and 0.8 milligrams of glycopyrrolate to help with bradycardia. Was also given 4 milligrams of dexamethasone after induction, and 30 minutes prior to the end of the case was given 4 milligrams of Zofran and 15 milligrams of Toradol postoperatively. Vital signs in the OR showed a blood pressure of 125 over 80, heart rate of 76, SpO2 of 98% on 4 liters nasal cannula with temperature of 36.5. Orders have been placed for IV fluids, PRN pain meds, early mobility, and routine post-op monitoring. What questions do you have? Thank you.